we're now recording. And this is everyone.
Welcome, everybody. We'll go ahead and kick off the meeting. It's now 3 o'clock. Let me ask Carrie first to explain what we have in here and how the audio and visual are being captured.
Yeah, so we are recording, and it's this owl is the microphone and the video. So for Pete and Artis, if you can just speak really loudly, which I'm sure you can do, and otherwise we'll be fine.
And we have 2 members who are on remote.
Yeah.
Okay. Ron Lee, can you hear me?
Yes, I can hear. And here, I'll turn my video on.
And Dr. Annie?
I can hear you.
Excellent. You can hear me? Would you call the roll for everybody then?
Yeah. Berg.
I am here.
Here?
Carr.
Here.
Holmquist. Here. Larson.
Here.
Malberg. Christoph.
Here.
Noble.
Here.
Skees.
Here.
Waterman.
Here.
Everybody here?
Yeah.
First order of business is to approve the agenda. Everybody read it? Any comments? Any suggestions? All approval say aye.
Aye.
Any negatives? 100% approval. Citizen comments.
We don't have any citizen comments on Zoom. Not seeing anybody in the hallway. Unless we have somebody coming from the corner.
That's the ghost of the South Campus.
Hey, Tori, if you can hear me, can you mute everybody else? All right, so I think that's citizen comment. There were 2 public comments that were submitted online, and they are attached. One of them was welcoming and thanking Jessica for joining.
Quickly moves to item 4, which is election of the chair and the vice chair. The past couple elections that I participated in or watched, we've had 2 people nominated at once for chair and vice chair. The normal procedure is to vote for, the normal rules of order are to vote for the chair first and the vice chair second. So I will open the nominations for chairman of the Board of Health.
I would move to nominate Roger Noble as chair.
Second.
I heard this one over here. I heard
Second.
Okay, Kyle? Are there any other nominations? Hearing none, I guess I could declare it unanimous because there's nobody to run against. But let's
Do we want to have a discussion about that, or
pardon me?
do we want to discuss that item, or?
Well, yes. Is there a discussion?
I'll jump in. I mean, I appreciate that Roger might be interested in doing this. Thought about a lot of it. I think for me, I think the importance of a chair is actually to help us have board decorum and stability. And I actually really appreciate that Roger was just reappointed. As right now being one of the people who's appointed the longest for our board. I think that, not saying that you need to be chair for 3 years, but I think it is important for us to have that institutional memory and move that forward. I know that myself, I'm up for election this year. Pam, I think you're up for election in 2 years. And so I think that just, again, that's my largest appreciation there. But also I think that the importance of environmental health to this board, and I appreciate Roger's leadership and knowledge of that.
All right, well,
Thank you. Are you going to respond?
yeah, I'll show up on time from now on. So thank you for the vote of confidence in that. I'll try to do my best. I think I'd like to invoke as much as Robert's rules of order as we can, just to keep things on track. So with that, yeah, look forward to doing it.
I'm supposed to be neutral as chair, but I'm delighted. So are there any other comments? Jessica?
I don't have a comment, but.
Okay. Moves the nomination for Roger, has been moved and seconded. The nomination for chair, Roger Noble. All in agreement, say yes
Yes.
or aye. Any negative votes? I count 9-0, so it's unanimous. Roger, do you want to swap position? And in honor,
Yeah,
I'll provide you with a,
I'll just stay there.
oh, take the gavel.
Make it simple. I like simplicity. All right, I guess we'll move along with the nominations for vice chair. Is there a nomination for vice chair?
I nominate Pam Holmquist for vice chair.
I'll second that.
All right, it's been moved and seconded for Pam Holmquist to be vice chair. Any other nominations?
I would nominate Bill to serve again. I think that he has led us through a pretty tumultuous past several months, and put a lot of work into it behind the scenes. And I appreciate your leadership during that time, and would nominate you to stay on in that leadership position.
You're very kind. As I've done twice before, I would be happy to be your vice chair. So, as long as I get the real vice, though.
Yeah.
So,
Other than Bill Berg, I'm having a tough time understanding what anybody's saying.
Okay, we'll try to speak louder.
Excellent.
Is there a second to Dr. Hybor's motion to nominate Bill Berg as vice chair?
I was withdrawing.
Oh, he was withdrawn.
Oh, you were withdrawing? Oh,
Thank you for the clarification. All right, with that, I guess Pam Holmquist has been nominated for vice chair. All those in favor say aye.
Aye.
Any opposed? Motion carries. Pam is the vice chair. Congratulations.
Yeah, if I could just thank everybody for the opportunity to serve in that capacity, I'll do the best I can. Thank you.
And Bill will be vice chair.
Yeah.
Good. We'll move on to the next item on the agenda, approval of minutes of the December 17, 2020 meeting. Are there any additions, modifications to the minutes?
I think the comment, I like this format. It's very concise, easy to read. And it's obviously shorter.
So I guess just a point of clarification on that, I assume these times are the times people speak and record. This has all been recorded, so really the minutes are the record. This is just kind of a summary.
Yeah.
So, all right. Is there
I
a
move
motion?
adoption.
All right.
Second.
All right. Been moved and seconded to accept the minutes as provided. All those in favor say aye.
Aye.
All right, thank you. Next item. Joe, I guess you have a discussion on the FTE, environmental health and sanitation
Yeah,
position.
thanks, Roger. I'll take this and then Christine, pass to Christine for the next item. So, going through the environmental health committee and the need to kind of boost that FTE on the environmental health, the land work side, septic system subdivision.
Muffled. Please speak up.
So, during our discussions during an environmental health committee meeting in December, we kind of identified some additional need for full-time equivalents in environmental health. To get to that point, we were unfortunate enough that Chris Ruth Bond in our environmental health that actually I hired many years ago, came back and has been working part-time for us. She is now going to retire, and this seemed like the perfect opportunity to increase her 0.5 FTE to 1.0 FTE. Going through the budget, environmental health budget's up about 14% year over year at this point, which, you know, as you know, it fluctuates. A big fall, big spring, nothing in the winter. So I feel pretty comfortable that we'll be able to cover this. I also know that there's some subdivision fee increases going through the legislature that will also help to support this position. So I would ask the board chair to move this to a 1.0 FTE, and I will take it immediately to the commissioners for adoption.
Thank you, Joe. Is there any comment or discussion?
So we increased staffing in environmental health in the last budget cycle, 1.5 positions, is that correct? Or 2 positions? And have we hired that second Pentarian?
Yeah.
In the budget review conversations that we had last year, we talked about 2 and made a decision to do a 1.5. And I sort of feel like part of it was, I'm definitely putting my city hat on right here. Part of how we presented that to city council, Kalispell City Council, was that we anticipated that the fee increases were going to help pay for that increase of 2 positions. So feels like sort of using the same justification to increase a little bit more. Has the fee increase been that much greater than?
Roger, it certainly is a nice increase, knowing full well that we've had kind of a COVID breakage in a lot of stuff. But it appears to be enough. It appears that we'll be able to support this with the septic system fees. And I know that there was some discussion on food sanitarian, food safety sanitarian versus land sanitarian. We did hire the food side of it, which is certainly a high benefit for the city of Kalispell. But it's also an opportune time to get a full-time equivalent, which it's not very easy to hire half-time sanitarians.
I think along with that too, is the increased number of septic permit applications and subdivision applications that are coming through the door right now. And just like Joe says, there's a huge benefit to being able to make a position offering as an FTE rather than a half-time FTE. So I think it's a great move. We need it. I would definitely support it. Is this an action item that we need to?
Yeah, you will need to take action on increasing the FTEs.
So,
what I hear is it's not just the increase in the fees, but it's also the volume and the increase.
Certainly right now, and just judging from, I've been through 2 big waves of development. Right now, we're still 2 years of pretty significant development or septic system activity in front of us. And when subdivisions start to go away, then people start doing a lot of minor subdivisions, splitting up the property. So I just, knowing where we are in this cycle, we're 2 more years before we see some slowdown. And at that time, we can reassess. Maybe we'll do something will happen by attrition, but there's certainly a need right now, and I don't think it's going to go away.
Is there a way to, sort of temporarily, do we have to increase the FTEs? Or do we take that surplus and just temporarily bump it up?
No, Roger, just if you don't mind, you do have to increase the FTEs, because not only do we have a budget, we also have an HR thing. It's not a temporary thing. It literally has to be increased. It has to be placed in the budget, and it'll come through the next budget cycle also. And hopefully we'll find someone rather rapidly. But, and then we did have some salary savings on some of the other FTE increases. So, but there's clearly enough land work going on right now to support this position.
Question, is this a committee report that you're summarizing?
No, this is actually a memo asking to increase from 0.5 to 1.0.
So it requires a motion and a second.
And it requires that to move it forward to the commissioners.
All right.
I'd be happy to.
Any
Provide
further
the motion.
discussion or comment regarding this item? If not, is there a motion? Would someone like to make a motion?
That's what I said.
Yes.
Yeah. Sorry. I'd be happy to make the motion.
So Bill Berg has made the motion to increase the FTE from half-time to full-time position for the Environmental Health Department. Is there a second to that motion?
I'll second.
Okay, thank you. So it's been moved and seconded. Carrie, why don't we do a roll call on this?
Any more discussion?
Yeah, just go that.
Okay. Berg,
Yes.
Dukenyak,
I'm abstaining because I couldn't hear the arguments for. Everybody's muffled.
Ibar,
Yes.
Holmquist,
I'm gonna stay because I vote on it later.
Larson,
Yes.
Albert, Noble,
Yes.
Deeb,
Yes.
Waterman.
No.
All right, I believe it was 5-2 with 2 abstaining. Or?
6.
6 to 2. 6, 2, and 1.
Okay, thank you. So the motion passes. Joe can present this to the Flathead County Commissioners. Thank you.
So, Roger, Christine's out there, so if you want to move to the next item.
Yeah, so the next item on our agenda is, so I printed this out. It's a little tiny thing. I don't read it right. Environmental health, food, and consumer contract. And this will be an action item. Christine.
Hello, good afternoon. Christine.
You might have to stand right there.
From environmental health.
You're gonna maybe have to wheel up.
You might have to take your mask off if you don't mind, because they can't hear very
I
good.
think you guys can probably hear me.
But they need to hear you.
Oh,
They're not
okay.
moving.
The speaker,
The speaker's right there.
Okay. Well, it's done, right?
Okay,
Yeah.
perfect.
Ronna Lee and
Um,
Annie are
They're having a
on.
hard time
Should
hearing.
we move the podium up?
Back up just like 2 feet. Your choice.
Okay, so what I want to talk to you about today is the food and consumer contract. So this is our annual contract with Food and Consumer Safety that it enters us into an agreement with Food and Consumer Safety, DPHHS at the state, to go to do in routine inspections. So with the retail food establishments, wholesale food establishments, trailer courts and campgrounds, public accommodations, body yard establishments. It would allow us to do peer-to-peer inspector training if another county needed that. And then the only really different thing about this contract from normal is that it would allow us to do COVID work. So COVID outreach if we needed to, some forms of alternate inspections, which currently we are not doing alternate inspections, but the contract would allow us to do that should we need to. So I would just ask that there's really no reason to not approve this. We need to approve this in order to get our funding from the state as we do inspections.
So, because they've added another duty, are they increasing your funding?
What do you mean added another duty?
COVID.
So it's not an additional duty, it's just an option that if we need to do alternate forms of outreach, like phone calls or virtual inspections, they will accept that and they will reimburse us for that.
Okay,
So
it is
it's not.
reimbursed. That's all I'm asking.
Yeah,
If there's
yeah.
additional funding. for
There's
that.
no additional funding, it's just that if we are unable to get out there and actually do a physical inspection, they would accept a virtual inspection
Okay.
or a phone call or something in lieu of a physical inspection.
And Roger, if I may, just, this is an annual thing. It needs to be signed by the board chair. And Christine, we also do pools and spas. And there's a few things that we do that other counties won't touch, and some counties won't touch pools and spas. I think our staff, we have a very competent staff in our food and consumer section, and we have to meet 90% of the inspections that are out there. And as you know, the board has established, we have a risk-based system, so we'll do 1, 2, or 3 inspections in a year, which I don't think the state really cares. They just set it at 2 or 1. But you have set risk-based inspections over time, which has really been a significant public health benefit to the community. So we always meet our goal. We usually way exceed it because of the fair and such. And as you probably know, Christine has shepherded us through a really rigorous FDA program that's really made our staff a lot better. So.
And we're continuing to work in that FDA program. Our grant is ending in July, but we will continue to work on that program. We did allocate one of our food staff to work, a small amount of time on that grant. And so we do things like standardize our staff, which is really great because, especially with the food grading program, we want to have standardization amongst our inspectors. And there are many other things that the FDA standards do, but I do believe it's a really good and useful thing.
So I have a follow-up question, kind of on the same track Pam was. So they added COVID inspections to this contract?
So they didn't add any work to the contract. They just allowed us to, if we need to do something in lieu of a physical inspection of like being out in the food establishment, because early on in the pandemic, we were held off from doing inspections. So if we need to do things like phone calls or virtual inspections, they will accept that work if we can't physically get out into a facility. So they just made that allowance that it's acceptable, we can do that if we need to.
So is it an hourly contract, or
No.
Or is it just a lump sum contract?
Based on inspections conducted. Well, among other activities, but primarily inspections.
Number of inspections.
And does
Questions?
anybody else have any questions for Christine? Okay, I guess with that, we would need a motion to approve the contract with the state.
So moved.
Thank you, Bill.
Second.
Okay, it's been moved and seconded to approve the food inspection contract with the Customs Services. All those in favor say aye.
Aye.
Any opposed? Carries unanimously. Thank you. All right, on to mosquito control. You can send in Mosquito Man.
Jake is on his way.
Good afternoon. Thanks for considering our plan today. So yeah, I'm here to answer any questions you may have about the pesticide discharge management. We are required to renew it once a year to comply with DEQ regulations in the Water Act. So that's the reason for the review. The changes we proposed are mostly in wording just to clarify the nature of one of our nuisance mosquito species. Previous wording made it sound more like it was a disease vector than it really is. To clarify some of the language concerning our drone, just to fit the UAS designation, which is FAA standard, and then to reflect some of our actual practices and capabilities that we have in the program.
So Roger, Jake, is there any substantive changes by table? I know that you're going away from the ramp method of looking for West Nile and you're going to PCR testing.
We have been using PCR testing for the last couple of years. Carroll College does the initial testing. If they find a positive result, it goes to the state for confirmation. We just do not have the time to speciate our samples and test by the ramp method during the season. Other than that, any substantive changes are just The only other thing I would note, I guess, is that we do not have a handheld fogger any longer. That's not the capability that we have. That's the only other major change I see in the table.
Any further questions, additional questions for Jake? With that, we would need a motion to accept or approve the plan, maintenance plan.
I move to approve the mosquito maintenance plan.
Second?
Thank you. All right. It's been moved by Kyle, then by Bill to approve the mosquito control pesticides discharge management plan. All those in favor say aye.
Aye.
Any opposed? Approved unanimously. Thanks, Jake.
All right, well, thank you very much.
Good luck. Committee updates. Joe.
Do you have some, Carrie?
Yeah.
I forget which one's the first one.
COVID-19 is the first.
Committees. So, Dr. Pete, do you have any updates?
Why don't you go first? Well, maybe Bill, for this part, maybe Bill can talk for just a minute about his numbers, projections, and then Joe can give us, I'm sure this will be, I presume this is a large portion of your health officer's report, but then maybe you can talk about the vaccination program and how we're doing with numbers and what that is looking like, because I'm sure many of us are interested to hear about that. So maybe Bill and then Joe on that. Does that sound okay?
Yeah, that's fine.
Okay.
Okay, we have the projection, the summary up at the top. And I'm not too far away to see, but you can see the yellow column, first four numbers, and there are the first 4 months, and then the beige colors are the months starting since that time and up to the current, which runs through, it started with our October meeting. So it's based on that time frame, typically the 17th, 18th, 19th of the month, as opposed to the beginning and end of the month. If you look at the percentage column next to the yellow and beige, you can see where the number of cases are. It peaked. My projection was very, very accurate. If you take 2 months at once, it was exactly 6,000 cases. The order was slightly different, and then if the month just ended, or if the month just ended, it's precipitously dropped. And it's hovering around that same percentage for the first, I think it's 9 days in this reporting period. Can you go to the graphic that's on our website? And let's look at pictures worth 1,000 words.
Do you want my help out?
Are you looking for the COVID stats?
Pardon me?
The COVID stats?
Yes.
That's what you're looking for.
This is at the Health Department website. This is the first page. She's going to click on the first line, and then will take us to an information page on which the graphics are shown. It's a strange looking, we just cracked 10,000 cases there in the upper right-hand corner. Fortunately, without any new deaths in the last month or so. And then can you go down that page a little bit? And we'll be looking at the total number of cases since the beginning. So it's about 11 months worth of data. The colors don't show up very, but it looks like a multi-humped camel. And over on the right-hand side, as it came down off precipitously from the very high, you can see a little humps there. And the last one, it's rising with daily variations. It's consistent with what we have in the rest of Montana. We saw 10,000 cases where 10% of the people, Montana has 100,000 cases out of 1 million. So we're seeing just about the same thing here as we do the rest of the state. And it's consistent with the trending graphs that the health officer has shown. Question is that it's going to continue to rise or drop? Let's hope it drops, but let's get people vaccinated and out of the at-risk category.
And I would say, mirroring that, the hospitalization rates have been have been similar as well. Will kind of have kind of followed that same trajectory of October, from October, November, December, where we saw hospitalization rates or the COVID patients in the hospital with testing positive for COVID respiratory illness were in the hovering in the mid-20s at a time, and now they're down for the past month or so, kind of like the teens-ish or so as far as active hospitalization. So it mirrors that that fall off, which is exciting to see. So, and then Joe, you want to talk about the vaccine part?
Yeah, let's just pop mine up real quick in my health house. We'll just do the front part of it.
Sure.
It kind of gives us I actually like, so I'm doing my own MD curves, the histograms based directly on the situation reports that you receive. And the only reason I tend to like what I'm doing is I'll just break my spreadsheet down and look at things differently. So I broke out November. You can see November was a slight climb. And as you see that trend line, that's actually a statistically driven trend line based on a regression analysis. And I'm not trying to woo you. I'm just telling you, I didn't draw that line on there. That's generated through Excel based on that data, because there's so much variation on reporting that putting that trend line on gives you that same thing we've been talking about forever. Is the slope going up, disease going up, slope going down, or is it plateauing? And we've used that for different triggers, and a lot of people like numerical triggers. From an epidemiological standpoint, I'd like to look at trend lines. I'd like to look at that slope on the line. So December, there could have been a lot of reasons why we had such a significant downtrend, but our January numbers, which are coming up, you can still see we're still a slight downtrend. We were always kind of wondering what was going to happen coming out of the holiday. You know, you would think we would have had a big burst, and the big numbers right at the beginning is the hospital lab was closed throughout some different times. So big report coming out of there. And I think the last 2 days, this is a little bit old now, but over the last week, we've been averaging right around 40 to 50 cases. And from a contact tracing perspective, that's certainly very manageable for our staff. It's interesting that I'm going to be very frank with you that the COVID money that we're using for contact tracing is not going to last forever. And we're going to look at how to streamline that program to, hit the most vulnerable. We're already really going after the most high risk for quarantine. And we've tried to make some other adjustments so we can continue to do that work with the realization that money is going to dry up, probably by the end of the fiscal year, unless we see an infusion of more money. If you go to the table next, a little bit on vaccines. This was as of last Friday, and we were just shy of 5,700 doses in Flathead County. And if you look, the second doses, those are all, North Valley and KRH. This week was our first week of doing second doses of Moderna in our clinic, and things are going great. And just to give you an idea about what we project, you've heard me project things like Tier 1B, which we're in 70 and older, the high risk or those patients with underlying medical conditions, 30,000 people easily. You would agree. It's at least 30,000 in Flathead County. We have an older population, and the hospital throws numbers out there, a regional hospital of 70,000 in their system. But if you look at us as 10% of the population, they feel Montana's got about 350 or 302 on B. So we're working off that number, knowing that this is a population that will have high vaccine uptake. So we may be 20 to 25,000 vaccinations to get through Tier 1B, vaccinated. That's not vaccinations. These are all 2-dose vaccinations. So you can see the task in front of us. A little bit about what's going on. We have a unified command with Kalispell Regional, very tight unified command with Kalispell Regional, and we have a unified command with North Valley. And we're doing different things to share resources. What we're sharing with North Valley is we're doing their scheduling. So it's something that we feel, certainly our call center feels that they can do. They can't use our electronic medical record, but we can use a spreadsheet and push a schedule to them, and they're very grateful about that. North Valley's going to try to do about 200 a week, and they're securing all of their assets they need right now. We're kind of in Kalispell, we're banking on Pfizer, and Pfizer is a 975 dose allotment that we get 1,170 doses out of. We're actually finding out we're getting a 7th dose out of one of those vials. We had 30 people called in today, primarily because of the Pfizer, the 7th dose out of the Pfizer, the little vial. We're banking on Pfizer. We're looking at 1,170 new vaccinated every week, knowing full well 3 weeks from now, we're starting to pick up second doses. So we're gonna, depending on how we break our clinics, we'll either do 3 or 4 day clinics, 780 for 3 days. Plus, we're gonna clean up the 400 doses of Moderna that we still have to do, so they'll be added into that. And then we'll start doubling back with the Pfizer. So, that's 1170 times 2, plus the Moderna that we'll have to clean up over the next 4 weeks, second doses. And then grateful for KRH. They had their head pharmacist down today with 2 pharmacy techs to teach us how to reconstitute the vials. They're little tiny things and you can't shake them. But Dr. Pete probably watching it, you're just rolling. And it's about a 10 roll. You've done a lot of this too, Jessica, but you can't shake it. It'll break the fatty acids away, fatty acetates away from the genome. So you have to be very careful with this vaccine. Very fortunate, we had 8 vaccinators from KRH today. So we are literally in a unified command, and that's our ICS talk that we all always work in. But we had a commissioner come down today, Randy Brodell, and I mean it's impressive. And literally, people cried before the shots. They're just elated, and you see it. People cry. They're so happy. They can't control themselves. So now I'm going to get that way. I'm going to quit. So we had a great day. We had a little scheduling problem today that got us behind. We had a bunch of 7th doses that came out that really got us moving through the call center to get more people down there. But it's a really well-oiled machine. We got really good people that work there, great staff. It takes about 50, 55 people to run a clinic that size. And we have 8 vaccinators. It takes 50 other people or 40 other people to support that activity. So very impressed with the staff, very impressed with our partners in KRH and North Valley.
Question, Joe. We have Pfizer and Moderna, and in some number of weeks, the third is Johnson & Johnson, which is in the approval process right now. I don't know how far away it is, 5-6 weeks probably, before they show up. Is there any difference in the efficacy of these 3 that would cause someone to wait 6 weeks, or get in line now and get it all today?
Well, my docs over here might want to jump in too, but right now you're looking at Pfizer and Moderna. They're both right at 95% efficacy. Efficacy is different than efficiencies when you talk about what you do in a very confined environment, but they're about 95% effective, which is super, super good. First dose, 70, second dose, plus 10 days, you're 95% durable immunity. You can expect you have 95% of the people will have a durable immunity that will keep them from probably being able to make other people sick.
And two, I mean, look at the studies aren't designed to compare head to head either. So you really can't say, if one's measured at 92 or one's measured at 94, you can't necessarily say the 94 is better because the study isn't necessarily designed to tease out that, to tease out that difference. So so any reason to wait, no. I mean, the sooner we get more people vaccinated, the sooner that we can start resuming our congregating and activities that people long to get back to with good reason. So no reason to wait. Along that line, how deep is the wait list right now? Do you have just Gestalt?
I actually checked before the meeting.
Yeah.
8,000.
8,000, and we're thinking, you said, you're thinking 1,100 a week, we think?
1,200, given the
Yeah,
extra doses.
so 1,200 a week, so, so I mean, so even the people calling now are probably six weeks waiting, to get, I mean, and I've been telling my patients still to call. I mean, if you're in 1B, on the website, I think the website has been a very nice update, where patients can see where we are in the 1B, and has some nice links for exactly how to contact the health department, how to get on the wait list, and those sorts of things. I think the updates on the website have been very well done with that. And so that patients know how to get on that. So that's good.
Yeah, this population likes to hear from somebody. So clearly 8,000 may not be that big of a number because that's the people that have called in. Then we start to sort and clean, and that we're probably 5,000 to 6,000 clean single records right now. And they're not stopping. I mean, we're getting 1,000 calls a day. We're swiping our form off the website a couple times. It'll hold 200 before we have to clean it. We're getting a couple of those a day. And, we really haven't pushed hard at this. This is all kind of organic right now. I think we're going to have a great uptake in this population. We'd really like to get to that education clearly before we get to the next, education cycle in September. I mean, that's a population that keeps schools open. So we really want to push to get to there. But yeah, we're excited about what's going on. We understand what's in front of us, and people ask to volunteer all the time. I am taking names on my notebook, a couple an hour, and docs, nurses, anyone, we're taking a lot of volunteers. It's going to take a lot of community effort to get through this, and I think the community is stepping up huge, and I'm really happy.
And have we had any indication yet about that number, that 1,100 number, going up even higher as the feds have started pushing for more doses? Any indication on that yet? Are we just banking on kind of the 1,100 a week for the foreseeable future?
Well, right now, it looks like we're going to bank on that allotment of Pfizer. We could fill in with Moderna, or we could literally, the hospital could keep some extra Pfizer up there and we can continue to roll in. I mean, realistically, it would be great to get to, and my staff, if they're listening, they're throwing darts, but if we could get to 1,600 a week, we could really accelerate this process, even that. So we're always finding better ways to be efficient as we deliver this. And we've come up with some things that really build some efficiencies in. And we're just going to keep plugging along. That's our job. And, I pride ourselves. This health department is the best health department when it comes to vaccinating communities. We've always been super strong with that. And we plan on doing it again.
One additional question?
I have
Go ahead.
one question I have, and I know that we're moving through this 1B and we know this population. But I can sort of see, we're gonna end up getting to the point where summer is starting to be here and we start to open up the park. Has there been any big conversation about where some of those frontline essential workers, maybe the outfitters, the restaurateurs, and where we address that side of the community? Knowing that that's still months away, but some of our forecasts say that we're not gonna have enough the vaccines really won't roll out until end of July. And I already have started to hear from either those people who own stores or those people who own sort of that tourist-based industry. The tourists are coming into the nerve.
So, Roger, it's okay. Kyle, I'm challenged with this for a couple reasons. I've had the people in the park say, how are you going to take care of my people that are coming from all over the country? So we get them in, they spend a couple weeks in, we get them vaccinated, we have 4 more weeks, we get them vaccinated, 10 days later they have durable immunity, hopefully, and they live other places. This is not their home. So I'm challenged with this. We know that we have snowbirds coming back, they're getting in, we're doing their second doses. You know, we want to get everyone to that durable immunity. I have had people say, how are you going to take care of my workers coming from all over the country? And I almost want to say, why don't you have your workers get those doses in before so they have durable immunity before? So I'm challenged with this. I'm very frank with you, Kyle. I think that when I get these and we're told, hey, how are you going to protect my staff that comes from all over the country? I'm going, well, maybe you should be protecting yourself before you come to us. So we're handling that, Kyle. I don't want to sound like a turd about things, but I am challenged with this. But you're right, and they're coming in, and it's a population that they're a population that are rather healthy and maybe asymptomatic as they come through and very social, and that could all be challenges. And if we were talking about the flu, that's why we took the flu shot and said, we need to get our young population done because they're making everyone else sick. So I hear it, I understand it, I'm challenged by it because they're coming here from other parts of the country that may not have a tier 1B that's 70 and older and underlying medical conditions. They may be frontline workers in Indiana for all I know. They could have been vaccinated then. So I hope they're not waiting to get vaccinated for it. So as you link in with these folks, you know, ask them what tier they're in and what, if their frontline workers can get done before they get here, we're all better off for that. But not just because I'm challenged, doesn't mean we're not going to do it.
I was going to ask.
I have a statement. I think there might be a question in there for Joe, but I listened to the county commissioners meeting on the 26th. And so I know that Joe, that you and I disagree in terms of the target of the vaccines. And you said it's specific for the novel coronavirus. And I have great respect for you, Joe. But after the last meeting a month ago, I had sent you a printout on the Pfizer vaccine, and it very specifically said that the target was for the M spike protein of coronavirus. It did not have anything in it about a specific, you know, novel coronavirus or COVID-19, and that's from Pfizer itself. And when they say 95% efficacy and durable immunity, this thing has only been tested for 5 or 6 months, maybe less than that. So durable is questionable. And then the basis for saying that efficacy is not human studies, not animal studies, but looking at blood tests. So if the target of the vaccine is the M spike protein, then the elevation of the antibodies, whatever you look at for efficacy, would be to the M spike protein and not a specific, you know, a novel virus. So I think that's important. And last I heard, Dr. Fauci was still saying, even if you get the vaccine, you still have to wear a mask to protect yourself, not just others. And so I'm just wondering how this all, how do you, how do you bring that together? How do you bring all that information that's variable together, including information right from the printout of Pfizer? How do you tie it together?
So Annie, just a couple comments, so first of all, the spike protein for this coronavirus, and I've done a little looking at this. I mean, the genetic sequencing between the first SARS-CoV and the second SARS-CoV-2 is like 95% difference in genome. And so all I can say is, yes, they all have that. They have 3 proteins on the viral coat, the M, the S, and another one that's not very consequential. But I believe they do have a target. I understand when you start to look at those inserts. I'm just going to call it what we would call a vaccine information sheet. You know, they've had to word those very carefully because it has been an expedited process of approving, an expedited improvement process. So, you know, we're learning on the fly. We're seeing some, you know, they earlier on they said, well, we can expect durable immunity for 90 days in those that were infected. Now it's moving to 180 days, and that's going to be in print very soon. So yes, the coronavirus is distinct to have that S protein, but at least what I've known, there's the genetic mutations on that spike protein is lower, closer to the viral coat, and what they're targeting is the end of that spike protein, and that may or may not be the same as the SARS-CoV. I can't argue that point, but it appears to be effective enough to elicit an antibody response.
Yeah, and I like the phrase you used, learning on the fly. And that seems, I think you seem to be an honest person. That's what I've seen so far. We are learning on the fly. So that's why I think it's important to be, you know, for the sake of our credibility, to continue to be honest like that. And so I appreciate that. And what I'm gonna try to do is get together the data that I have that should at least help people consider that it's controversial as to whether or not the genetic sequence has actually been isolated of a novel coronavirus, because it is controversial. So it's going to be arduous, but I plan to put that information together because that's really key. And again, I appreciate you, Joe. Thank you.
And maybe we could just have a one-on-one and we can just kind of talk it through.
I would love that. Thank you.
Right, yeah, I mean, and two, yeah, I mean, the point being as to how durable it is, right? Again, it's all how the studies are set up, you know, to get approval. They wanted to see it they wanted to see, I think 3 months, correct, is where they cut the study off to submit it to the FDA. But then they're still continuing to follow those people. And we don't know how long it's going to last because it hasn't been 6 months since administration. So then once the 6 month time has come in, they'll tabulate the numbers and see what the protection is like at that 6 month point, and then submit it for publication. And then I presume they're going to continue to follow these patients at 9 months, at 12 months, and then that's where. And so it's not just. I actually, maybe not learning on the fly, I don't think is necessary. I would actually go against that a little bit. We are ongoing. We are reviewing the data as it continues to come in to see how long it lasts, because it is a brand new vaccine. So we are learning from time. And
I like that. And Roger, if you don't mind, one more thing. This is so fun to be up such a wonk. The new J&J. So it went through phase 2, what looked like a 70-odd% efficacy rate. Now that they're wrapping up phase 3, they're seeing 90%. And it's a 1-dose vaccine. And that was basically put out there, and we thought, well, that's all going to go to these developing countries, and we were going to stick with our stuff. I would love to see, this is a viral vector vaccine. It literally just, the end point is it's giving that same genome for reaction in our body. It's just getting in an adenovirus, and that's all that's happening. So that single dose, after what we're doing in planning, would be a dream. Single dose, 90% efficacy. We could run from 8 to 10, 2 times a week with multiple cycles, and we could be done in 3 weeks. But we could be done. That's a single dose. That would be my dream, that we would have that. It will be interesting with the feds just buying another 100 million from Pfizer and Moderna, that they may not be so apt to buy the Johnson & Johnson, which I'd probably shed a tear because I think it would be so much easier on us. But it's a different mechanism, but it just delivers that same genome to react to. But that's literally, I think you mentioned, it's probably 3 to 4 weeks from finishing up and submitting to FDA.
And I want to ask a question. The answer is probably we don't know, but when I pose it for the COVID committee and in this meeting next month, is there any documentation of people who either been immunized or have had the virus, certified to have the virus, that have got sick a second time? Or is the same thing, has anybody come down with the case who has been immunized? And I would charge our committee to look for that, and also the department.
Yeah.
It certainly, if there's none, it argues that you ought to get out and get the vaccination as quickly as you can. And I've not seen anything in any literature anywhere to say that we've had repeat cases in either case, if you're vaccinated or got the bug.
That's how the study, Roger, one more time. So that's how the studies are actually set up. But I can tell you, just because you've had a vaccine does not really get you to that point of durable immunity. We had a long-term care facility that
In general, right?
just blew up. They had vaccine, and 3 days later they had a huge cluster of cases. So you really have to let the vaccine work. And we have to report those as a vaccine adverse response, and because they want to know if that stuff happens. But
And they are reported through the department, is that correct?
Well, we're following them for case investigation as long-term care, but we also have to report them to CDC as an adverse event.
Just one super quick comment, and that is that I sent it in an email to y'all, but facts don't change. I think we can all agree that a fact is a fact, reality is reality, but our understanding of facts does. And historically, for thousands of years, we advance science by humbly questioning the current so-called science. So I think it's important that we, humbly question what's going on. That's how we advance.
Well, thank you, committee, for your report. That's real interesting. Does the board have any further questions for the committee or any other comments?
I think just in closing, I mean, I think everybody's excited about the vaccine, and I think the overall enthusiasm and the down curve of the slope. I mean, I think it's not a time to be cavalier yet. I think the community, I think most people in the community understand that. I mean, there's a light at the end of the tunnel, and we're getting close, and we see that, but it's not time to have a COVID party and get a bunch of people together, and and I think we just need to continue to reinforce that message as well. We're not there yet, but buckle down, and we will get there.
And just to clarify, I touched on it briefly about the educators in our community. So they're on the list. We're actively trying to get them up. So they would probably be vaccinated hopefully before the seasonal workers.
You could speak up or speak more clearly.
Yes. So I'm worried about the educators and their position in the vaccine. So I know that you have to go by the governor's guidelines. So I was just kind of hoping that we could get maybe a discussion or comment on when they might be considered for vaccination, since they are kind of frontline workers for our community.
So what happened was the CDC rolled out this whole tier system, and we were going to abide by it and make a few changes. What happened was the governor, who literally listening to his very educated transition COVID committee, said, no, we're going to target the people that are dying from this. So they literally said 70 and older, underlying medical conditions. And these are pretty significant underlying conditions. And so they pushed all of the frontline workers, which educators were in, down to the next year. And so even though if we would have never seen anything else change, we would have been doing educators, frontline workers, all of that would have been being done now. But the governor, and we are abiding by his tier, and the governor moved them, and we're gonna try to get through as fast as we can to get the educators done.
And to be clear, I believe educators are 1C, and so that is still above the general population. So it is still going to be before everybody, the general population will be, we're getting the people who are at highest risk of dying.
It's a good.
All right. Thank you. All right, I guess we're moving on to the Community Health Coordinating Committee update.
That's Pam's baby, but I have just a few things.
Yeah, we had a really good first meeting with Joe since he came on with the committee, and I think we got a lot of discussion going forward. We haven't got any documents yet. We're working on, of course, on the lease and all the other moving parts of how the clinic will operate in the building that they're in now, and how we'll coordinate and do some sharing, and Joe was all on top of that, so he may want to add to that. But I think it was a really good first meeting, and things are moving forward, but we don't have any documents yet, so hopefully we'll get those.
You know, I'm just going to add two things. So Carrie and my focus, and certainly Carrie's helping with a lot. We're getting family planning separated, all the separation things done for family planning since it's staying. So we're moving on that now with the electronic medical record and some of the other things we need to do. Other things we need to do, we need to, tomorrow, an architect that's done a lot of work will actually design this building and has the plans for our other building will be in. And they're going to, we're going to walk through, and he's going to give us a very accurate assessment of the square footage that they operate in. And we're going to talk about some add-ons because, you should hear the numbers for medical space. It's $22 a foot, and that's, you build it out. So we've done so much for, Kyle's there too. So we've done so much for them. We know that the health center is a super important part of this community. And we're doing everything we can to get this separated. Move our relationship to landlord-tenant, which that's what they want, and make sure that everything is assessed appropriately. And I think everyone's moving in that direction now. I think you agree.
Yeah.
And I think I don't want to belabor the points, but we're going to do the square footage. We're going to talk to the architect about, because they do a lot of commercial and medical. We're going to get a pretty good list to start to work from on looking at some of those costs, ongoing costs that we have. So that's about it for now.
Yeah.
Any questions for Pam or Joe on that?
Are we still on appropriate timetable for separation to occur as projected? What was it, May?
May 31st,
May 31st,
and
yeah.
they need to get it done by then. There may be some areas like IT, we're trying to figure out IT, that we may have to give them a little bit of support for a couple months, maybe a short-term contract till they can get their own IT. That's been kind of they're not sure they get it done in time. But the actual separation, the employees, becoming their employees, the lease taking effect, all of that has to happen May 31st. It's a tight timeline, but that's what they asked for.
This is what's good about not wearing a mask.
So was that time frame?
What's that?
Was that date requested by them?
Oh, yeah, yeah.
Because it was timing, because it came down to the timing of the grant renewals, right?
It was timing of the grant renewal. The original thought was that they'd wait until February of 22, but they pushed it forward and they got the grant changed to HRSA. And now that end time is May 31st, 2021. So we got to get it done by then. It's going to be tight.
All right.
And then who's going to be, is there a medical person that's going to be overseeing family planning as they have now separated? Or will we have some sort of use agreement with the community health companies that they're going to come back and kind of supervise over family planning?
Yeah, well, and Karen, please add to this. So we have 3 medical directors at this point. I only know 3. It would be nice to consolidate 2 of them to work under the health department's functions. Right now, they're not. We can move forward. We will easily be able to put our agreements into place with them. That's not going to be an issue. So the medical direction, that's a slam dunk, at least from my perspective, and I think Gary would agree that that's an easy one. There's a lot more challenges out there that are going to face us.
Wow, short time. All right, I guess we'll move on to other committee updates. Are there any others? We're good there, so we're ready to go to department reports. Animal shelter, Cliff is there. This is always my favorite one. This is a real good one.
Good afternoon, Mr. Chairman, members of the board. Russell. I'll be as brief as I can.
And we'll have to have you speak up because we got the owl, or come forward.
All right.
Yeah, they can't hear online.
No problem. So I just thought today I'd take a few quick minutes to kind of go over the last year's annual report, and I think you all got that. And what's kind of nice about this report, our software company, PetPoint, is probably the largest software company out there. And so without divulging individual names, they compare us in this report to our state organizations, and there's 10 that use it, and there's 1,700 some in the country. And so what we're doing well is we're getting animals out of the shelter fast. And, pardon me? Alive as well. Yeah, the pie charts there have some pretty fine print there, but this year, down below there, thank you. This year, our combined dog and cat euthanasia rate was like 1.9%, and that's the lowest it's ever been. So I wouldn't say we're going to ever beat that or maybe even equal it, but we've been running 2 to 3%. Cats are more fragile than dogs, so even though we take in more dogs, sometimes it's a pretty even number. But the big one is our length of stay, as I say, and part of the reason for that is we cheat. We're doing an excellent job of getting dogs back to their owners, close to 60% on dogs. The industry as a whole does a miserable job with cats, and I think it's just because cats are kind of a little more disposable in people's eyes and that sort of thing. That's my own theory, but a lot of shelters out there, more than half, are private organizations, and many of them, like the Humane Society in Northwest Montana, right here in town, they only take owner surrenders. So they really have a low return. But we're still, as Bill said, thank you, getting them out alive. And that's kind of what we all strive for. Normally, when you have a short length of stay, it's because maybe you're a huge municipal organization that takes in way more than you can handle. And so you have to euthanize for space and time and that sort of thing. And that's the other benefit of having a short length of stay. So we can all be really proud of those numbers. It was interesting in 2020, for the last 5 years, we've been averaging about 1,000 dogs. And you can see we're down almost 25% on that. And I like to think that that's because more people are spending time at home that they haven't been. And their animals aren't getting bored and digging out and climbing out. And I think a lot of them are looking out in their backyard saying, well, there's a hole in the fence out there, or the gate has a big gap in it. So once in a while, there's a benefit, and so that's to the animals. But anyway, we have a lot to be proud of, and it's nice to be able to be compared to your peers.
and I promise I don't lord it over them either. The shelters in Montana have not a unified by name organization. We have a monthly teleconference and share information, which helps everybody. So that makes it nice. So the other thing that I thought I'd show is, I don't know if the wide history, this one's going to be harder to read. Next year, at the end of next year, the county's animal sheltering program will be 40 years old. And and for those who haven't seen it, we do have a nice big version of this on the wall. We did it at the end of 2018, but kind of a typical story of municipal shelters, but an amazing one. And the shelters kind of had 3 phases. It was at the landfill until 1998. And there was no room up there. I mean, if you saw what passed for the shelter, it's a 10th maybe the size of what we have now. And if you look at those animal numbers, like 3 and 2,500 to 3,500 dogs, and almost that many cats. And so the euthanasia rates were terribly high. And so when the county moved down to 225 Cemetery Road, you know, the numbers dropped precipitously. But we still, I know Joe will remember this, we were euthanizing with a gas chamber. And that's a horrible thing for people in the sheltering industry to hear, until I tell them that replaced a 20-gauge shotgun. And I did find a receipt for the shelter buying a shotgun back in the 80s there. And so we've come a long way. And then, of course, when the health department took over in 2008, I mean, you can see the numbers took a big drop again. And they've been down nice and low, single digits for the last several years on both dogs and cats. And again, cats are much more fragile than dogs are. And so we have a great staff. It's always a shock when we replace somebody, because there's only, counting me, there's only 8 of us. But we replaced a couple in the last couple of years, and they've been just great people and very committed. And we have a vet that we all love and who has really embraced shelter medicine. And it's as Dr. Malberg can tell you, it's now a separate curriculum in a lot of the vet schools, and it's more of a herd mentality type of thing. But I think the vets that I've met that have gone from private practice to, or split their time, get very energized by shelter medicine. And so our vet's a great one. And we have a good relationship. She works for Calm Animal Care in Kyla, and Barbara Calm for years has been a good, not always a critic, but she's been very outspoken and very communicative. And she's had a lot of good ideas and a lot of good support. So we have a lot to be proud of too, from where we started to where we are now. And so this last year, as I said, just to finish up, I think I kind of said all that. Our proportion of owner surrenders to strays is about the same. It's about 3.5 to 1 or so strays over owner surrenders. And so looking for reasons for differences in these last couple of years, I mean, we're at about the same number of cats. We've been averaging a little over 500 cats, and about halfway through my tenure, next month will mark 11 years. But we were having a lot of trouble with feral cats, accidents in the shelter with bites and scratches, and employees as well as volunteers. And so the word came down that we need to stop taking feral cats. You know, we can't adopt them out, and they're a hazard, and et cetera, et cetera. So when we did that, it infuriated the cat lovers of the area. And so looked into starting a program that's been really good, and that's that barn cat program. And so now we take them by appointment only, and only when the vet's there. Then they go in and out the same day. They go out sedated, vaccinated, neutered, and we only take them when we have a home for going out. And that's taken up the slack. So We still get in trouble because, as I've mentioned in the past, we follow industry guidelines on how many cats and dogs we should house, and it's more of a function of adoption rates than anything. And so our magic number, using that calculator, is around 15. We try not to get over 20. And so once in a while, we have to, especially in September when the first cold night hits and everybody that's been feeding stray cats starts bringing them in. That makes people mad, but it doesn't last too long. And I think people are getting more and more used to that. So, so we have what appears to be a good system and a good staff and a good leadership all the way up to the county commissioners. Thank you for the support. Any questions?
Those cats that are the barn cat program that you do, what are those categorized under adoption or return to field?
Return to field.
Okay, so that explains why that return to field number is higher, because they get categorized under that, in that column.
Right.
Can I comment, statement?
Please.
So I was able to visit the shelter and I was extraordinarily impressed. And I think something that you talked about with the feral cats is something that we see often in the industry, and that's that they can't be adopted out successfully, but not only returning them to the field not only allows them to live the life that they want, but also helps to really reduce our disease population in the rodents, keep the nuisance rodent pet population down. So there's actually feral science that supports having feral cat colonies to help improve public health of the humans in the area as well. So it's really wonderful you guys have built that program.
It's you know, it's like so much of sheltering nowadays. There's so much good information and things that are already in practice that, you know, you just emulate and plug them into your own. But yeah, it's been a huge help on getting, and the other thing is that makes a lot of people, cat lovers, mad is especially when we have to put, you know, somebody on a wait for a spot to open up for a feral cat. Feral cats are notorious for not thriving in captivity. So they wind up, they get sick, they get stressed, they get upper respiratory diseases and things like that. They wind up getting euthanized. And so that is a known thing. And a lot of the cat lovers in the valley do not follow the science out there. And so they don't believe that. They think that somebody's making that up. But it's a proven fact. So it's been a big help.
So Roger, if you don't mind, I think some of the most significant things that happened when the health department took over was health. We had a lot of animals die in the kennels from different diseases, as you know. But the other thing is we adopted a strict policy: no animal leaves without being altered. So I think that's probably, when you look at our whole global animal population, probably the strongest thing we ever did was say, no, we don't adopt anything else that's not altered.
That also gives us the dual ability to have some veterinary oversight for our staff, which is good, and to have somebody in there 2 days a week so that the animals that come in that might have to be euthanized because you can't adopt a dog out for $100 if you have to put $1,000 into surgery. And so that's made a big difference too. But yeah, the oversight that we get has been a huge help.
All right, thanks, Cliff.
Thank you very much.
Look forward to your report.
Appreciate it.
I guess with that, the next item on our agenda is population health.
I'm just going to quickly take care of that. From this time forward, Lonnie that's on our Zoom meeting will probably be doing this, some of this at least. So I'm just going to race through. I'll just mention some of these programs. You know, the tobacco use prevention program. We in the Montana Cancer Screening Program, we're a little short-staffed, and if you look, our numbers were a little low in October, but they're climbing back up in the screening program. The tobacco, we're continuing to struggle in there because of our health promotion folks. Our population health folks are doing so much with the COVID response. But if you go down a little further, Carrie. Safe Kids, Safe Community. Once again, Wendy Olson does most of this program, and she's spending a lot of time And we're checking in with our grantors on this to try to keep them up. And we're doing everything we can to do our COVID response and still maintain our activity in these programs. So these are all Wendy Olson Hanson's programs, a lot of 25 car seats and responsible alcohol sales. And Sharps program, does everyone know what we do with the Sharps program? It's been discussed. It's an absolutely wonderful program we have with solid waste. We literally provide through the pharmacies Sharps containers that can go out. We're trying to keep needles, sticks, and other things happening in open containers. And so the Sharps program has been around for quite a long time. And it really is effective. And it's a partnership with our solid waste program and our pharmacies that help distribute and collect those the Sharps containers. So if we go on down, I wanted to just mention this is my favorite report because I like it's not that I like disease, but I clearly understand disease. Chlamydia, as you can see, that's pretty typical numbers for new cases in a month. Gonorrhea, hepatitis C, a lot of these are being picked up. This was something that you brought up in December about why is hepatitis C like it is. And oftentimes in screening, because there's a specific population that hep C is pretty prevalent in, if the hospital is screening those before invasive procedures, then that's where we pick a lot of the hep C up. The other things that are on there, we had a listeria case, and it was interesting. Lisa Dennison goes, "Wow, why do we get a listeria case?" Well, listeria is out there, but it only impacts, very, infirm, pregnant women have miscarriages because of listeria. Listeria is always a problem from a food safety perspective because of the fact that listeria will grow readily at refrigeration temperatures that we maintain our refrigeration at. I always say a shelf life for lunch meat should be about 7 days in the fridge. And that's because that's a big source of listeria cases. The last thing is we have some Shigella. Shigella is not uncommon. Why we had 2 cases, I don't know if they were travelers or if they just picked it up, but Shigella is very closely related to the E. coli strain. Transmits and incubates about the same. So if there's any questions, I've taken. If not, we'll just keep rolling.
I think it's very interesting to look at the influenza epi curve in light of risk mitigation strategies for COVID, and that as everything that we've done for COVID has also caused a market decrease in community influenza activity. And so I think it speaks to the fact that the things that we've done for COVID, we as a society will not tolerate doing these things forever, and they will come to an end when the pandemic is over, but yet they work, and they work to prevent spread of communicable disease. And so, and the influenza curve is further validation of that.
It's a really good
So
point.
do you mean that's just because people are getting vaccinated more now?
Well, people are getting, I mean, influenza spreads largely the same way COVID does, right? And so all the things that we're doing to decrease COVID spread, everybody washing their hands, spreading out in a big room like this, that, if we got all around the table, we could just as likely, I'm sorry, not as likely because influenza doesn't spread as easily as COVID does, but the same measures that we've taken have caused the influenza rates to drop off precipitously as well. So I think it further validates the measures that, that we've done and that's been taken.
All right, any further questions for Joe on the population health? If not, we'll transition to Kirk and finance.
Here it comes. What a great system. Kirk, you've seen it already, so.
Dr. Yellow? Well, good afternoon. This is the December financial report. Probably first out, we're starting a new budget cycle. So we'll probably meet in March with the finance committee to have a preliminary budget presented. And then in April, we'll have final approval by the board at that point. And so that's sort of the start of the process, and anything that comes up, obviously we'll get a hold of you. So the cash balance for the general fund looked pretty good this year. Or I shouldn't say this year, through December, 1.5 million versus maybe where it was last year at about 1.2. We had some funds that were transferred into the general fund from the CARES Act, so helping us out on some expenses. Obviously vaccine expenses coming down the road. Immunization clinic, still holding in there for not having travel vaccines and some of that yet. Doing okay. The AR balance down a little bit due to the collection on the flu vaccine process that happened. So AR balance coming down a little bit as that's been collected. Environmental health doing well, revenue's up. Joe probably mentioned 14% or so year over year at this time period. And expenses are under control, so good news. No updates for the capital improvement area. Home health, cash balance about 158,000. The AR balance is up a little bit. That's due to some issues, technical issues that are happening with Medicaid. They had a RAT process previously where they brought in payments before their appointments and so on were finished, sort of a prepayment. And at the end of the day, they've gotten rid of with that prepayment process, and they've gone wholly to reimbursement, which is added to the AR balance. So that's up a little bit, but as things go on, we'll start collecting that. No updates for any of the program dashboards. Some of the coronavirus grants have been closed out. We got one that'll just get finished up. And that's it for me. Any questions on the financials this month or in general? No red flags? No red flags.
Nice.
How about yellow ones? No yellow ones yet, yes.
If Bill's happy, I'm happy.
Right.
All right.
Okay.
Thanks, Kirk.
Thank you.
You bet.
All right, thanks. We'll move on to questions about department reports. Joe, is that a specific topic?
So, I'm not sure what that's for.
It's a carryover because we don't do all the reports. So if there were questions about reports we didn't review.
So, great. We're on to board member comments. So one thing we thought maybe we change or modify on this a little bit is if the board members wanted to make suggestions on other items they'd like to see at the next meeting or future meetings, or if there's anything that you would want to include in this meeting. So floor is open.
Well, I made a comment earlier. If we can do that, it'd be great, so I'll say it twice without repeating it. I have to make another comment?
Yes, please.
This is, we have a new member of the committee. There are a couple of the committees that we're going to make some changes. We have a new chairman. And it's your job to make the assignments. I was on a couple committees as an observer, and so some of those should be submitted. You and I are on a couple of committees together, because you have oversight, and I was the chairman. So this is the time to do it. He's the guy to talk to.
Well, I guess, yeah, if you have a committee that you're interested in being on or want to serve on, that's the people that we want on that committee. So I guess I would suggest we give Joe a list, or you can email me of what you want to do, and then we'll get assignments going.
Carrie, if you can send the list out to everybody, of the committees and the assignments that are current?
I'm gonna do a copy of last year's committee.
Okay, I mean, like for me, it's pretty simple. I know what my specialty is and where I'm gonna land, so I know where your specialty is. Okay, well, good point, thank you.
And Roger, if you don't mind, and maybe this is bringing back to why we even had this board member comment. It was really to charge the health officer with additional duties, like look things up, give us some information, a lot of statistical stuff. Or if it comes up that, something that comes up in the board meeting is intriguing and you want to pursue it a little further, I would add that to my health officer's report. So, this should be a very fluid time when you just say, hey, we'd like to know a little bit more about this. I hope we could get back to really using it to charge the department for additional information that you think impacts our community. And it may be
Along those lines, Joe, I'd like to see more complex analysis of the cases and the death. Not just looking at numbers, but also looking at, concomitantly, how many tests are being done. For instance, the number of cases increased after our lab cranked up the number of tests that were done. The U of M increased, that new U of M lab, it was like middle of October, and then KRMC shortly after that. And that's when the case, so I think that's important. Hospitalizations, to my knowledge, looking at the rough data, hospitalizations decreased when we got BAM outpatient therapy, increased when we used remdesivir. So just more complex analysis.
We'll look into trying to formulate some sort of either a graphical or tabular way of depicting cases over time with hospital and deaths. And it's interesting you brought this up because it's actually, we're pushing this press release out today. Annie, you know that much of the testing that happens around many diseases happens in the hospital. So when a person gets hospitalized and they have a GI or respiratory, they're going to go through all types of laboratory testing to determine what it is. Basically because of the severity of the illness and such like that. We just had 15 death certificates deposited on us that were non-hospital that are being attributed to COVID. So I've looked at some of those death certificates and, this has been a challenge for a long time in public health. And it's getting better. That used to be people died of respiratory distress, even though the underlying problem was influenza. And now we're getting, the docs are much better at reporting that underlying condition that caused them to die. So I'm not making any excuses. I'm just saying that hospitalized people are probably pretty confirmed. Their illness is pretty well established because the illness is severe enough to be in there. Outpatient activity, activity that's driven through exposure to cases, that may be a little bit more difficult to understand, but I've always been pretty confident about hospitalization rates and attribution to an illness, basically because I know that they're getting tested a lot. And Dr. Pete, you might agree or add or whatever, but we pick up most gastrointestinal illness that we do pick up is in hospitalization people, because if they're got screaming diarrhea, docs aren't going to let that continue in a hospital. They're going to do stool testing and we find out. Many diseases or illnesses are severely underreported, and oftentimes, and I can speak to my foodborne outbreak background, often it's hooked to a hospitalization with a confirmed case with some genome sequencing that links it to another case. So there's a whole spectrum of reporting that goes on in this, and quite frankly, I think hospitalization rates and illness attributed to hospitalizations pretty well known, but, you know.
Well, I'll send you a little more complex analysis, because part of what I'm thinking about is, like, for instance, and I'm going to be real brief because we got to end this, but you know, remdesivir added 5 days to the hospitalization. So no matter, even if the person was ready to go home otherwise, it added 5 days. So when we're looking at the number of people in the hospital allegedly from COVID, it's important to look at, are they in there because they've got 5 days of remdesivir, or do they really qualify to be inpatient? And I know for a fact one of my patients was hospitalized for 2 days, declined getting the remdesivir, and she was sent home. So, that's another topic, and I'll send you, Joe, some of the things that I would like to see included in our analysis. I just think we could be more intelligent. If we only have, we can give a more intelligent analysis if we have more than, you know, one variable. We just look at number of cases over time, look at what could be confounding variables.
Yeah, that's fine. I don't want to disappoint you if there's information that I can't get out of the hospitals.
You have not disappointed me so far. Some things you just can't do. So.
Okay. Just keep remembering that.
We all heard it.
I guess, go ahead, Annie.
I'm done.
I'd like to commend Joe on drafting up the protocols for his in-person meetings, and the board last night for working through that. And we have a promulgated policy now. I think it really enhances discussion. So I would take it that this can then be used as a format for other boards to implement. So,
it's public record.
Yeah. So, okay. Well, thank you. So, anything else? I guess.
We need a better microphone system.
The one thing I have is just, Joe, just to encourage some regular communication going to just sort of what public officials should know about how vaccines are going. I've just discovered this because I just did a little bit of travel around the state. Surprised to see that in different counties, things are looking differently. So for those of us in the Flathead to have some good ideas of how things are going and stuff like that, you're doing a great job. So I just commend you on that, but just have to keep that sort of regular communication so that all of us who are in public office are sort of on the same page.
And Kyle, you've been a great conduit for me to talk to the city council, and I would do that at any point. Just don't do it when I'm scheduled for like this too.
Right.
Those are long nights. But I would, I actually, as you know, that was a very enjoyable discussion we had at the council meeting. And I turned around and had a very enjoyable one with Whitefish, even though they were adopting a mask use policy, and it wasn't always pretty, but it was productive.
No, and I think that there's some of those conversations that we have, if we're going to include the other cities into having boards on seats on the board, maybe taking some advantage of a fifth Monday or something like that to have some of those conversations might be helpful.
Oh, I would like to echo Roger's comment on the committee last night, working through that document, and I am ecstatic that we're meeting in person in the same room. I think this is a much better way to go, and I really like that. I also want to take this opportunity to thank Jessica for applying for the board and then getting on the board, because I think her expertise is going to be valuable going forward. So thank you for stepping up.
Thank you. I'm really appreciative that you believe in me enough to have me here. So I just hope to be able to help however I can. So whatever committee doesn't have people, I can help there. I'm happy to do it. So thank you for having me.
Any other comments? All right. I have a motion to adjourn. So moved. All right, thank you.
Great meeting. Thank you so much.
Thanks, Dr. Annie. We'll see you next time.
It's pretty good.
Come by, yeah.
Visit us.
Oh, we're 17 minutes early.